Hello everyone. In the last video of access cavity preparation series, we are going to discuss the pulp space anatomy and access cavity preparation for maxillary and mandibular molars. We will start with the maxillary first, molar. It is the largest tooth in the maxillary arch. It is the first tooth to erupt in the maxillary arch at the age of 6 or 7. It has 4 major cusps: the mesiobuccal, the mesiopalatal, the distobuccal, and the distopalatal cusps. And it also has a small cusp, sometimes present on the mesiopalatal cusp. And if it's present, it is called the cusp of Carabelli. So this is the cusp of Carabelli. Now, the mesiopalatal cusp is the largest. From an occlusal aspect, if you look at this tooth, it is somehow or somewhat rhomboidal. The crown of this tooth is wider buccolingually than mesiodistally. It is also wider in the mesial aspect than the distal aspect. The buccal and the palatal sides are not parallel to each other, as you can see. The mesiobuccal cusp is more buccal than the distobuccal cusp. One of the most important anatomical landmarks that you can observe looking at this tooth from an occlusal aspect is the oblique ridge. The oblique ridge is formed as a result of the union between the triangular ridge of the distobuccal cusp and the distal ridge of the mesiopalatal cusp. This tooth has 3 roots: a curved mesiobuccal root, a fairly straight distobuccal root, and a large, long palatal root. Each of these roots has at least 1 root canal. However, most of the times, in around 90% of the cases, this tooth will have 4 root canals. The 4th root canal will be located in the mesiobuccal root. The mesiobuccal canal orifice is located under the mesiobuccal cusp tip. The distobuccal canal orifice is located slightly distal and palatal to the mesiobuccal orifice. Now, the palatal canal orifice is centered palatally. The second mesiobuccal canal, if it's present, it is very small and it's usually covered by a lip of dentine. The second mesiobuccal canal is very small and tiny, and it's usually covered with by a lip of dentine. Therefore, we need magnification and good source of light in order to find it. Okay, it can be found. So when we try to look for the second mesiobuccal canal, or the MB2, it can be found on or just mesial to a line connecting the main mesiobuccal canal orifice to the palatal canal orifice. So it can be found on this line or just mesial to it. These are the 2 locations where you can find the second mesiobuccal canal, or the MB2. The 2 mesiobuccal canals can exit the root in 2 separate foramina, or and this is Vertucci type 4. Okay. So if you look at the image on your right hand side, you can find that the 2 mesiobuccal canals exited the root surface in 2 separate apical foramina, and this is Vertucci 4. Or they can join just before exiting the mesiobuccal root in a single apical foramen, and this is Vertucci 1. Or in a small percentage of the cases, you can only find just 1 mesiobuccal canal, and this is Vertucci 1. A study of the root canal anatomy of the Now, there was a study conducted on extracted teeth of the Jordanian population. They got 100 extracted maxillary first molars, and they looked at the root canal anatomy in the mesiobuccal root, and they found out that a second mesiobuccal canal was present in around 77% of the studied teeth. Of these teeth, 35% showed type 4 canal system and 27% showed type 2 canal system in the mesiobuccal root. This study was conducted using the tooth clearing technique, where they cleared the extracted teeth and they injected ink into the pulp space and they studied the root canal anatomy. The pulp chamber of the maxillary molar is fairly rhomboidal, and it has 4 pulp horns: a mesiobuccal pulp horn, a mesiopalatal pulp horn, distobuccal and distopalatal pulp horns, just corresponding to the cusps of the large cusps or the main cusps of the maxillary first molar. Now, the floor of the pulp chamber is dome-shaped or rounded, and it is located just apical to the cervical line. Okay. The mesiobuccal canal orifice is closer to the buccal wall than the distobuccal canal orifice. So the axis cavity will also be rhomboidal, and the buccal wall of your axis cavity will not be parallel to the palatal wall, because the mesiobuccal canal orifice is more buccal or is located buccal to the distobuccal canal orifice. So the line or the wall joining the two canals will not be parallel to the lingual wall. The distobuccal root and its orifice is closer to the middle of the tooth than to the distal wall. So you will notice that your axis cavity will be located mesial on the crown, mesial to the oblique ridge. It's not in the center of the tooth. It is located more towards the mesial side of the tooth. Now, the distal canal and the palatal canal, the palatal and the distobuccal and the palatal roots, most of the cases they will have just one root canal in each of these roots, and that's Bertucci type 1. The distobuccal canal is the shortest, and it leaves the pulp chamber in a distal direction. The distobuccal canal normally curves mesially in the apical half of the root, so it will not be a straight canal. It will have a slight curvature towards the mesial side of, especially in the apical part of the canal. As we have mentioned previously, the palatal canal is the largest and the longest of all 4 canals, and it leaves the pulp chamber as a round canal which generally tapers apically. So the diameter of the palatal canal will become less and less as we move apically. In around 50% of the roots, it's not straight, it curves buccally in the apical 4 or 5 millimeters, and this curvature will not be seen on radiographs because it is in the buccal direction. If it was in the mesial or the distal direction, then we can see it on radiographs, but when the curvature is in a buccal or in a palatal direction, we won't be able to see it on radiographs, because the radiograph is a 2-dimensional image of a 3-dimensional object. So the 3rd dimension is not visible on radiographs. So although when you look at the radiograph, you may think that the palatal root is fairly straight, and you would assume that the palatal canal is a straight canal and easy to clean. However, in most of the cases, the palatal canal will curve in a buccal direction, making instrumentation a little bit difficult. As the tooth ages, secondary dentine will be deposited on the roof of the pulp chamber. Therefore, the size of the pulp chamber will become reduced, and locating the canals will become more difficult because the pulp chamber will become calcified and the pulp chamber is reduced. The size of the orifices of the canals will become reduced, and then it will be difficult for us to locate canals or even see it on the radiographs. See on your right hand side, you can see on the radiograph that you can't really see the root canals for this tooth, for the upper left first molar, because of calcification. And this is as a result of deposition of secondary and tertiary dentine. Therefore, we have to look at preoperative radiographs before starting access cavities to avoid complications. We can measure the distance on radiographs between the occlusal reference points, such as the cusp tip, to the roof of the pulp chamber, and see how much do we have to penetrate or to drill through enamel and dentine in order to reach to the pulp chamber. That therefore preoperative radiographs are invaluable tool to help us visualize the access cavity on teeth and the anatomy of pulp chamber. And this is how an access cavity should look like on the maxillary first molar. Let's talk about the steps and the starting point for the access cavity on maxillary first molars. In the previous or in the first lecture of this series, we said that the external anatomy of the crown of the tooth will help us visualize the internal anatomy of the pulp chamber, and the anatomy of the pulp chamber will determine the shape of the access cavity. And for the maxillary first molars, we said that the pulp chamber is trapezoid in shape, and therefore our access cavity will be trapezoid or rhomboidal in shape. Our mesial border for the access cavity is the mesial marginal ridge. This is one of the strength points of this tooth. Unless the mesial marginal ridge is involved and destroyed by caries, we should preserve it because it provides strength for this tooth. If we damage it unnecessarily, then we will end up with a weak tooth that can fracture on function after doing a root canal treatment. Therefore, the mesial marginal ridge should be preserved. Because if we drill unnecessarily towards the mesial side under the mesial marginal ridge, we won't be able to find the canals because the root canals are located distal to the mesial marginal ridge. Now, our distal border will be the oblique ridge, and again, this is a strength point for the maxillary first molars. The buccal wall of our access cavity is not parallel to the lingual wall because the mesiobuccal canal orifice is located more towards the buccal side than the distobuccal canal orifice, and the palatal canal orifice is located and centered in the under the mesiopalatal cusp tip. The mesiobuccal orifice is located under the cusp tip of the mesiobuccal cusp tip. We will need an endo-access burr and an endo-Z burr. We use the endo-access burr first to drill through enamel and dentine and to penetrate through the pulp to the pulp chamber. The entry point or the start point will be in the middle of the central groove between the line and imaginary line connecting the mesiobuccal and the mesiopalatal cusp tips, and between the oblique ridge. So we have to imagine two lines. The oblique ridge is the distal border, and the imaginary line connecting the mesiobuccal and the mesiopalatal cusp tips is the second line. On the central groove between these two lines is our entry point. We use the endoaxis to drill through this point. We draw our initial outline, a triangular or rhomboidal axis cavity. Then we drill deeper through dentine until we penetrate to the roof of the pulp chamber. Once we have reached to the pulp chamber, we switch to the endo-Z and we de-roof the pulp chamber, removing all the roof of the pulp chamber. As you can see that the canal orifices are located on the line angles between the walls and the floor, and you can see the developmental fusion lines on the floor. Let's move into the maxillary second molar tooth. The maxillary second molar tooth is a smaller replica of the first molar. The roots of this tooth are less divergent and sometimes fused. The tooth has mainly 4 main cusps: the mesiobuccal, the distobuccal, mesiopalatal, and distopalatal. It also has 3 roots: distobuccal, mesiobuccal, and palatal roots. Each root has at least 1 root canal. 4 root canals are less likely to be present in the second molar than in the first molar. So the mesiobuccal root of the second maxillary molar is less likely to occur than in the maxillary second mesiobuccal canal in the mesiobuccal root of the second maxillary molar is less likely to occur than in the maxillary first molar. Now therefore, because the roots are closer to each other, the orifices of the canals are closer to each other, forming a flat triangle, or sometimes they are located on a straight line. So the orifices of the canals are very close to each other. The studies have shown that in 60% of maxillary second molars, it will have 3 roots. In 70% of the cases, there will be 1 mesiobuccal canal in the mesiobuccal root, and in 30% of the cases, almost 1/3 of the cases, will have 2 mesiobuccal canals. In 25% of the teeth, they will have 2 roots only, not 3 roots. And in 10% of the cases, it will have just 1 root with 1, 2, or 3, or 4 root canals. The axis cavity preparation sequence will be exactly the same as we did with the maxillary first molar. However, the axis opening will be smaller because the orifices will be closer to each other. And the shape of the axis cavity will be a fairly rounded triangle with the apex towards the palatal side and the base towards the buccal side, because it will have 3 canal orifices. Now, moving into the maxillary third molar, third molars or wisdom teeth they display great variability in terms of morphology and anatomy. They can have separate roots or fused roots, and there are no rules for axis cavity preparation or for root canal anatomy for third molars. The pulp space anatomy is less predictable, and they can have a reduced or increased number of canals. So we're not going to talk about third molars because there are no rules for third molars. Let's move into the mandibular molars, and we will start with the maxillary mandibular first molar. The it is the first permanent tooth to erupt, and it is the tooth that most frequently requires a root canal treatment because it will be in the oral cavity longer than any of the other permanent teeth. It has 4 major cusps: the mesiobuccal, mesiolingual, distobuccal, and distolingual, and a small 5th distal cusp. And that's how you can distinguish between right and left mandibular first molars. It is wider mesiodistally than buccolingually. It usually has two roots, a mesial root and a distal root. Each root can have 1, 2, or 3 root canals. The usual canal configuration for this tooth is 1 root canal in the distal root and 2 root canals in the mesial root, mesiobuccal and mesiolingual. Of these two mesial canals, the mesiobuccal is usually difficult to clean because of its tortuous path. And in around 40 to 45% of the cases, the two mesial canals will exit the root in one apical foramen, and that's Bertucci 2. And in a larger or a greater percentage of cases, they will exit the root in 2 separate foramina, and that's Bertucci 4. The incidence of 2 distal canals in the mandibular first molars is around 38%. So a small percentage of teeth will have 2 distal canals. When only 1 distal canal is present, it is usually centered in the distal root, and it is usually oval in shape and it's large. It emerges on the distal side of the root surface, so the short of the anatomic apex. So it's not coincident with the anatomic apex of the root. It exits from the distal side of the root. Sometimes a third mesial canal can be present between the 2 mesial canals, between the mesiobuccal and the mesiolingual canals. Sometimes we can find a small middle mesial canal. Okay, so we have to look for it. Now, the pulp chamber is wider mesially than it is distally, and the tooth will have, in a newly erupted tooth, will have 5 pulp horns corresponding to the cusps. The lingual pulp horns are longer and more pointed, and the floor of the pulp chamber is dome-shaped and rounded, and it's located just apical to the cervical line. The axis cavity will be located in the mesial 2/3 of the tooth, preserving the distal side of this tooth. Now, the axis cavity is again rhomboidal or trapezoidal in shape, regardless of the number of canals. The mesial border of our axis cavity will be an imaginary line connecting the cusp tips of the mesiobuccal and the mesiolingual cusps. The distal border will be an imaginary line connecting the mesiobuccal or the central groove on the buccal side and the lingual groove on the lingual side, and the entry point will be a midpoint on the central groove between these 2 lines. We start our axis cavity in the entry point, and then we drill through enamel dentine, and once we reach to the pulp chamber, we draw the initial outline of our axis cavity using the endoaxis burr, and then once we've reached to the pulp chamber, we switch to the endo-Z burr, and we start deroofing the pulp chamber completely, avoiding any damage to the floor of the pulp. We should remove the roof of the pulp chamber completely, otherwise remnants of pulp tissue and bacteria can still be hidden in the pulp horns, causing failure in the future. Moving into the mandibular second molar tooth, this tooth again is a smaller replica of the mandibular first molar tooth. It has 4 cusps, mesiobuccal, and mesiolingual, distobuccal and distolingual cusps. It is wider mesially than distally. It has two roots mainly, mesial root and a distal root. Um, the, um, the mesial root usually has two canals, unlike the first molar. There is usually only one distal canal. The mesial canals have a tendency to fuse in the apical third and giving rise to one apical foramen. So that's Bertucci 2. So, because, as we said, second molars, they have a tendency to have fused roots, or the roots will be closer to each other when we compare them to first molars. Now, another variation of the root canal anatomy in mandibular second molars, when they have fused roots, the fusion will give rise to a horseshoe-shaped root canal system. When you view them in a cross-section, they will give rise to a C-shaped canal. And we call this canal a median buccal canal. So when you look at the canal occlusally, or if you have a cross section, you will see it is C-shaped. And this is how it looks like on radiographs. Compare the tooth number 6, the first molar, to tooth number 7. You can clearly see the bifurcation in the first molar. However, you can see the roots are fused in the 7, and we usually suspect or expect fused canals or C-shaped canals in these cases when we have fused roots in mandibular second molars. If you look at this radiograph on the second molar tooth, you will see that the roots are clearly fused. Compare it to the first molar. In the first molar, you can see the bifurcation area. It's very clear. When we do a root canal treatment, this is how the canals look like. So they have one C-shaped root canal orifice, but then this canal will branch into 4 main canals. So treating root canal treatment for second molars is tricky, and you can have unexpected root canal anatomy. Another variation in the anatomy of mandibular molars is what we call an extra root. If this root is located, an extra third root, if it's located in a distolingually, then we call it radix intomolaris. This root will be on the lingual side, distolingual side of the tooth. If the extra root is located on the distobuccal side of the tooth, then we call it radix paramolaris. That's it for access cavity preparation and root canal anatomy for molar teeth. Let's move into another small topic and discuss what can go wrong during access cavity preparation. So we're going to talk about the errors that can happen during access cavity preparation. The first one is failure to remove the pulp horn, failure to de-roof the pulp chamber completely, and this will lead to leaving remnants of the pulp tissue, bacteria, and this will lead to failure of treatment, and it will cause discoloration of the tooth after doing root canal treatments. Sometimes you hear patients saying that my tooth has become darker after doing a root canal treatment. This is one of the reasons why teeth can become darker after root canal treatment, is if we leave behind remnants of pulp tissue, if we fail to remove the pulp horn completely, then we will leave these dead tissues behind. They will disintegrate with time, causing discoloration of the tooth and possibly failure of treatment. In this case, this is failure to remove the palatal shoulder. We said in the maxillary and sometimes in the mandibular anterior teeth. We have in the cervical area, we have a bulge of dentine on the lingual side of the tooth, and it's called the palatal shoulder. If we fail to remove it using Getz-Glidden, then our file will be deflected and the access cavity will not provide a straight line access to the apex of the tooth, leading to so the instrument will not be able to touch all canal walls because it will be deflected labially. Therefore, the instrument will be working under stress, causing a fracture of the instrument or unnecessary cutting of tooth structure or radicular dentine in areas, and failure to clean the lingual wall of the canal. And in this case, the burr orientation was wrong, leading to gouging of the labial wall of the anterior tooth. So the direction of the burr has been directed more towards the labial side, leading to overcutting on the labial side and gouging. And this will obviously weaken the tooth structure. If we continue drilling in that direction, then we will end up with a labial cervical perforation in the maxillary or mandibular anterior teeth. And in this case, sometimes the tooth will become non-restorable and it will be destined for extraction. In this case, the burr has been introduced to the pulp chamber, and the dentist continued drilling in the floor of the pulp chamber, causing damage and furcation perforation. And also in this case, sometimes it can be difficult to amend, and the tooth will be planned for extraction. From the laws of canal orifices locations, we remember that the canal orifices should be located on the line angles between the wall and the floor of the access cavity. In this case, you can see that the access cavity is overcut. It's large in size, larger than necessary, leading to weakening of the tooth structure and possible fracture in the future. This is the opposite. This is an undercut access leading to missing canals. And if we fail to clean these canals, obviously the root canal treatment will fail. Now, another error during access cavity preparation for posterior teeth, premolars and molars, failure to de-roof the pulp chamber. So sometimes when you start drilling, you get an exposure of the horn of the pulp chamber, and some of you will think that this is a canal orifice. However, this is just an exposure to the pulp horn. The canal orifice is located at the level of the cervical line, so we have to de-roof and remove the roof of the pulp chamber in order to be able to see the orifices. If we expose the canal, the horn of the pulp chamber, bacteria and pulp tissue will remain under the roof of the pulp chamber, leading to failure and discoloration. And remember that the floor of the pulp chamber is gray. So when you see white or yellow dentine, you have to know that this is the roof and it's not the floor of the pulp chamber. Then you have to remove this roof using the EndoZ burr. A mouse hole effect: if we expose part of the canal orifice and leave the other part covered with the roof, then we will end up with a mouse hole effect. This is a correctable or amendable error. We have only to cut the roof of the pulp chamber and expose the canal orifice completely. Okay, so in the previous 3 lectures, we can summarize it saying that a correctly sized and sited axis cavity is one of the most important factors in enabling efficient and effective root canal preparation and obturation. So our axis cavity preparation is the key for successful root canal treatment. If you start your axis cavity preparation correctly, then the next steps, you will make the next steps of root canal treatment easier. And if something goes wrong during axis cavity preparation, you will most likely end up with complications during root canal preparation and during root canal filling and obturation. So start your axis cavity preparation correctly in order to end up with a successful root canal treatment. I just want to show you, this is my last slide. I want to show you that the pulp chamber size is dynamic, and it can become reduced in size by caries or by operative treatment. So this is a mandibular first molar. As you can see, the carious lesion has resulted in deposition of tertiary dentine, and this pulp horn will became reduced in size because of deposition of tertiary dentine on the roof. And then when the dentist started drilling and they put the pulp capping material and the restoration, again the pulp has responded by deposition of more tertiary dentine. So the pulp canal or the pulp chamber anatomy can change in shape and in size during our life as a result of deposition of secondary and tertiary dentine, and as a result of caries, operative procedures, and tooth wear. So what we have studied about the anatomy of the pulp chamber, it's not fixed. The pulp chamber is not fixed. This is just the typical or the ideal shape of root canal anatomy. However, we have to rely on our preoperative radiographs to study the anatomy of the tooth we are working on. Thank you for listening.